Hello, everyone. Welcome to Big Ideas. Today, we have Dr. Tanika Chakraborty with us, who is an associate professor at Indian Institute of Management, Calcutta. She researches on development economics, economics of gender, and health economics. Welcome, Tanika.
Thank you so much.
So, Tanika, which big idea are we going to be talking about today?
I think let's talk about health, both because that's my more recent, in the last 4, 5, or 6 years, I've been working on that. But also because there is a lot of policy changes that India is going through. And health is really under-researched in India, particularly. So, yeah, let's talk about that.
So, from my understanding, I think around 1975 or something, India shifted its focus from healthcare, like providing hospitals or building hospitals, to public health, which is immunization and building accessibility, basically. Roads and everything would come under that, taking care of air pollution, water pollution, all of that. So, where are we right now? Which model are we now going for? How successful has that been for us?
That's right. I mean, a big change. And if you look at immunizations and primary health care, India has come a long way in terms of infant mortality. We have done remarkably well in terms of reductions in fertility, for instance. We have done very well. Now we are thinking about the opposite side of it, in fact, how to increase. But generally speaking, so health has 3 aspects. One is primary health care. So all the immunizations that you're talking about, all those come under that. That has in most countries, and I would say it's publicly provided. Then there is secondary health care. And then there is tertiary health care, which is hospitals, right? For big health shocks, you need to go to the hospitals. Now, this is where right now all the policy focus is, because most countries, and India is definitely one of them, most developing countries world over are shifting from this model of public provision, direct public provision, which is building hospitals, right? Government hospitals where poor people could go, and to a model where the private market provides hospitals, but the government only subsidizes care, right? So in some sense, we are moving from this direct provision of healthcare, tertiary healthcare, to a public-private partnership model. And we are not the only ones. If you look at most developing countries, Vietnam, also the emerging countries like China and Indonesia, everywhere across the world, governments are moving from the previous model to the new model. One of the big reasons, of course, is the amount of strain it puts on budget. Right. So India also, if you we all know from independence time, we have had this government healthcare, government hospitals where everyone could go. But a big challenge has been that the government hospitals are overcrowded, they're understaffed. So most of the time, while healthcare is free in these hospitals, most of the time people cannot access that, right? Because it's so overcrowded. So over time, instead of, in addition to, of course, building new hospitals, etc., in order to increase access, like you said, the government since around 2000, I think mid-2000s, since around 2005-6, governments have moved from this older model to a more public-private partnership model. And if you look at the data, it basically shows that in the last 10 years, the spendings, overall government expenditure on direct provision of tertiary health care has actually gone down. At the same time, there has been a remarkable increase in the amount of money that the government is spending on the social health insurance schemes, right, which is the public-private partnership models. Yeah.
So, in your research, what have you found? Is India doing better under this? Are people taking this up? Or is there a division if a certain section of the society is taking this social insurance more than the other? What have you found?
So see, like everything else, it's a mixed story. There is no one clear-cut answer. But ultimately, we want, so the whole idea has been to improve access for people. right, through this model, or through any model, through any kind of public healthcare model. So the questions that we need to ask is, how much has it done in terms of improving access? How much has it done in terms of improving health outcomes? And one of the big challenges that India has always faced is very high out-of-pocket expenses, right? Health expenses, especially the catastrophic health expenses. How much has that been addressed by this switch to the public-private model, partnership model? So what we were looking at is, first of all, who takes up this insurance? Although on pen and paper, it's free, right? It's not even subsidy in most of these health insurance that exists, of course, all over India. We know of Ayushman Bharat, but many states have their own programs as well, like Arogyasri in Andhra Pradesh, Telangana, like Shastro Sathi in West Bengal. So many states have their own programs as well, which is more or less the design is the same for tertiary healthcare. Now, who takes up these insurance? Who has access to this insurance? So we have to understand that what is traditionally going on in rural economies in India. So traditionally, rural or urban actually, in poor households, if you think of this, most of the activities happen around informal networks. Right? So you are part of a network, and when you are in trouble, when you are met with some kind of shock, let's say a health shock, you go to your informal network to borrow, right, to address that shock, to mitigate that shock. Now, imagine that you were going to your informal network. Now the informal network knows that there is this health insurance model which is provided by the government, which gives you free healthcare. So it's in the interest of the informal network to actually motivate you and help you to utilize, take up, to adopt that the new model, right? Because it becomes free. The informal network doesn't have to bear the costs anymore. So what we find is that people who have been part of informal network, who have strong connections to informal network, they are the ones who are taking up the social health insurance programs provided by the government more and more. So our study is essentially based in the context of Andhra Pradesh and Telangana for the Arogyasri program, but the general idea holds in all these programs. So people who are well connected to informal networks, they are the ones taking up. People who are not so well connected, they are not taking up unless they're faced with a shock. Tomorrow they're faced with a shock, then they take up. Because remember, even if the premium is free, there is a huge transaction cost to actually access those kind of health insurance. You have to exactly know where to go. You have to know how to fill up the forms, which forms to fill up, etc., etc. So these actually, it's not like walking over to the next government hospital that is next door. You have to do all these bureaucratic steps. You have to fill up all those steps to be able to access that. So typically the insurance, the informal network that you have helps you do that. So that's the first step in terms of access. The second step that we must remember is that when we are talking about public-private partnership models, what does it mean? It means that earlier you were going to a public hospital, a government hospital. Well, it's very crowded, so you most of the time you don't end up going there, and that's why you spend a lot of money out of your pocket going to a private hospital. But now the insurance allows you to go to a private hospital and access that healthcare for free, right? But the problem is, in India, if you look at data, 70% of the private hospitals are based in urban regions. And much of our population is not based in urban regions, right? So the big difficulty now is a different type of access, which is basically that, if you want to access private hospitals, you have the insurance, but how do you go to the urban region to access the hospital? What if you're in an emergency? And forget about emergency. Think about the most common need, which is delivery of child. Right? So for delivery of child also, you need to travel that distance. So what we find is that, especially in the context, so we do this in the context of Arogyasri, we find that people who have access to Arogyasri, they are more likely to take it up, in the sense that they are more likely to have their deliveries in private hospitals. That's fine. That's actually great, because people are utilizing this. And in fact, we find that out-of-pocket expenses fall, right? But that's a good story. The bad story, or the other side of this, is that we find this happens only for very few people who are either living very close to the hospital and who were anyway going to a public hospital before, and now they have just switched to a private hospital, or they were anyway going to a private hospital and now they are using the insurance to get the cost of the private hospital reduced. So the out-of-pocket expenses are falling because people were earlier using the private hospital, but now they can cover that with the private insurance, with the public insurance, or people who were earlier going to government hospitals and now switching to private hospitals. But there's this big chunk of the population who was having their deliveries at home or non-institutional places. They keep on having at non-institutional places. So we are not able to really reach out to the large population that we need to. So in terms of increasing access, I have to say that we still have a lot of way to go in terms of increasing access, right? So that's about access.
There's a lot to unpack there, but I just want to ask you, what's been the outcome? Like, has there been positive health outcomes from this initiative? Because if you're saying 2005, 2006, it's been good about 20 years now.
Yeah.
So have health outcomes increased in those two states that you mentioned?
Right. So what we find, first of all, you have to see the NFH's data in 2020-21. It shows that even with this free health insurance available in most states today, in addition to the central program Ayushman Bharat, only about 40% of the households actually have any health insurance. So that could be also out of pocket. You're paying your own private health insurance. Everything combined, only 40%. So the question is, why does 60% of the population still doesn't have health insurance even when it's free? Right. So part of the reason, as I said, could be that you have to be. So there are reasons why there are impediments to taking up to adopting health insurances. Your informal networks are helping. Not everyone has informal networks. So we need to build awareness campaigns. We need to help people to come into the program. So that's one part of the story. The other part is that institutional deliveries, right? Institutional deliveries has been in the past very low in India, and that has been one of the biggest challenges of the government. Again, we have done remarkably well in terms of improving institutional deliveries through various kind of programs. Now, how much role has this public-private partnership model played? We'll try to look at that in Andhra Pradesh and Telangana. So what we find is that women are going to private healthcare for deliveries, but only those women who were earlier going to a public healthcare, right? Or people who were anyway going to a private healthcare, paying out of pocket, they are now using the social health insurance scheme to. So there are people. It's not like nobody is accessing. There are people who are accessing, but they were anyway introduced to the institutional healthcare model. But there are this big chunk of people who were not accessing institutional care. They were having deliveries at home or non-institutional facilities. They keep on having it. So we have not been able to touch them. And part of the reason we find is because hospitals are so far off, we have not been able to touch them. So overall, we find that in terms of, when we are looking at, when you're thinking about childbirth, the obvious health outcome that you think of is infant mortality. So we do not find a major impact on infant mortality because of this. So yes, it's helping a few people, but it's not helping in the magnitude so much that, or the access is not increasing so much that it will have a big impact on infant mortality. So that's one thing. But on the other hand, there is one small, I would say, positive effect that we do find, which is that now, because private healthcare has become free because of the insurance, And we know that there is a gender bias in India, right? And what we find is people are more likely, more willing to go to private hospitals, even when it's the birth of a girl child. So for the girl child, actually, the accessing private healthcare has increased much more than the boy child. And we tend to think that the PNDT Act actually meant that nobody is getting ultrasounds before delivery. But it seems that people know what they have, because there is a pattern that we see in the data that people are behaving in the systematic way that earlier when they had, so before the program came in, people would be taking their, going to the private hospitals more when they expect a boy to be born. But now when they expect a girl to be born, they are still, now they are going to the private hospitals more because they have become free. So it has in some sense helped the girl child.
It's an interesting result. Which countries have been very successful in implementing such a scheme, and what can India learn from that?
I think one of the countries that I know of is Vietnam, has been very successful in implementing this program and universalizing. So universal healthcare is what we are thinking of. Is that so? What data tells us is that Vietnam has near universal implementation. So what happened in Vietnam was that in addition to this public-private partnership model, Vietnam also, the government spent a lot of money in building hospitals. So that access that we are talking about, that people do not have access because most of the private hospitals are in urban regions. So Vietnam has had this simultaneously, these two policies together. So I think what we can learn from there is we need to have an incentive model, either an incentive model where private market also goes to the rural regions, right, spreads out more than in the few urban pockets. So we need to incentivize private hospitals to do that, or the government will have to build more public hospitals. Yeah.
Thank you so much for doing this with us today, Tanika.
Thank you. Thank you very much.